So now, who do we have next? I need to.
I am the next presenter.
Yes, Prof. Namrata, please start.
So thank you so much, and I would be talking to you about phacoemulsification in compromised corneas or in corneal haze. And there are no financial or proprietary interests, and I would be talking about the off-label use of air as well as trypan blue dye. So whenever you have a case of corneal opacity and cataract, the bigger question is whether to do a combined procedure with keratoplasty or to do a cataract surgery alone. And whether you would do a combined procedure or a cataract surgery alone would depend upon where is the opacity, whether it is paracentral or peripheral. And in most cases of central corneal opacities, you would either combine it with the DSEC procedure or a DMEC procedure or a full penetrating keratoplasty procedure. In all these cases, we generally prefer to put a monofocal intraocular lens. The keratometry video keratography is often difficult. So in these cases, we use a standard K. Biometry, either ultrasonic B scan or immersion scan can be done, but IOL master often is not possible in these cases. And of course, for the IOL power calculation, if you're doing a DSEC triple, you would account for the hyperopic shift. And likewise for DMEC, where only slight amount of hyperopia is aimed at. Now, this is the algorithm for cataract surgery with corneal opacity, just to show where you would do phacoemulsification alone. Sometimes you may have to do phacoemulsification with optical iridectomy, and sometimes first you have to treat the cornea with PTK and then do a phacoemulsification. However, for combined procedures, depending upon what level of opacity is, one can do a SALC triple, ALTK triple, DALC triple, DSEC, DMEC triple, or a PKP triple. This is our review article on phacoemulsification with coexistent corneal opacities, which we had published for greater details. Now, whenever the endothelium is suboptimal, for instance, Fuchs dystrophy with cataract, in those cases, one has to always see whether the visualization is good or not. If the visualization is good, one can do a phacoemulsification or cataract surgery alone, and then later on take a call for endothelial keratoplasty or triple procedure. But if the visualization is poor, then in those cases where corneal thickness is more than 650 microns and cells are less than 800, then a triple procedure is planned. When you're doing a phacoemulsification with the corneal opacities, it is important to know which half of the cornea is clear, because from one half of the cornea, one can do the phacoemulsification procedures. So just to give some examples, this is a case of ocular surface disease, chemical injury with cataract. And here, the trypan blue staining of the capsulorhexis is done. And as you are underneath that opacity, go through the rhexis in one go. Don't leave the edge of the rhexis underneath the opacity. This is followed by the hydro maneuvers, the nuclear emulsification, irrigation, aspiration. Always remember to put your red glow on, retroillumination on, otherwise you may forget to put this on. And then it is always good to suture, especially in cases of chemical injuries where the corneal thinning may be there. Now, this was a case of healed keratitis with dry eye. And this was a one-eyed patient which had an optical iridectomy too, and didn't want to undergo a corneal transplantation procedure because of infection after corneal transplantation in the fellow eye. Notice again, trypan blue staining is done. The incision is planned here because this half is absolutely clear. Capsulorhexis is being done, and when you are underneath that opacity, you have to go in one go. Do a little eccentric capsulorhexis because this is the area where you will see, and this is also the area where patient will see in the post-op period. Little eccentric phaco is being done here because the chopping and the formation of the crater would occur eccentrically here. The retroillumination glow is on so that there is a good contrast between the grayish fragments and the red glow that is present. And the second instrument is very important because the nuclear fragments, etc., may be camouflaged underneath this opacity, and you need to get it into your area of visualization. Phaco in situ, that means you emulsify, you eat, you emulsify, you eat. And that is mainly because the red glow gets better and better. And as the red glow gets better, the visualization improves. Now you can see the edge of the rhexis here, and the foldable intraocular lens implantation is being done. The patient doesn't obtain a visual acuity of 6/6, but does become ambulatory in the post-op period. Now, this is again a case of dry eye healed keratitis followed by in a brown cataract. And here you have to expand your area of visualization because this is also a small pupil. And again, this half of the cornea is clear, and notice it's a very hard cataract, but essentially the same principles which I had discussed earlier would be followed. And eccentric phaco and phaco in situ, which means chop and eat with the retroillumination on will be done. Now, this was a case of chemical injury where there is a white cataract. It is a graft with the sutures in, but still you have to do the white cataract because this is only about 3 months old and you can't remove the sutures. In such cases, whenever a pannus is there, it is always best to remove the pannus. And notice how clear the cornea becomes. And when it gets blurry, put a blob of viscoelastic. And as you put a blob of viscoelastic, for that split of a second, it will magnify and it will also become clear. So you can initiate your step and complete capsulorhexis as well as the subsequent procedures in this case. Now, this was a black and a white cataract. A white cataract because of the opacity, and black because it was tattooed, and there's a synechia here which has to be released. And again, your area of expansion or area of visualization has to be expanded. Just as you see the rhexis which gets lost underneath this haze, one can also pick it up from the intraop OCT microscope. And again, the principles of nuclear emulsification will remain the same. You do it from one half, and as you put the intraocular lens, in fact, the visualization becomes better and the opacity looks smaller, although it's easy to do when it's difficult to do when you're doing it under the operating microscope. And in this, the pupil is also enlarged. And followed by this, in the table itself, we would inject pilocarpine to see what is the state of the pupil, because that is the area which will remain in the post-operative period also, from where the patient can visualize. In cases of Stevens-Johnson syndrome, we've already published our results, and these are cases which are high risk, and you cannot do a corneal transplantation in these cases. So here, again, the nylon hooks are used. It's a temporal incision. The endoilluminator is put inside the eye to see where you have to chop. And now it is put outside the eye to see where you have to put the intraocular lens. And these cases also, again, will not get 6x6 vision, but the patients would become ambulatory. So this is just to show some of the results from the cases that we encounter for chemical injuries as well as for Stevens-Johnson syndrome. So visual acuity is 20/40, but then it makes them ambulatory, and these cases are high risk for grafts. So those problems of high-risk grafts are obviated. Then I think femtocataract also has a role to play in corneal haze. It doesn't completely allow you to do a complete capsulorhexis or allow you to do chops in all the quadrants, but it does soften the nucleus. And then there would be fill in the blanks sort of areas which can be dealt with more amicably. So just to show a case of corneal haze where rhexis is initiated with the femtosecond laser. And notice it's not complete here, but then you just have to fill in the blanks, in the sense you have to just join these areas, and chops will be present at other areas, but not in this area. But then it helps you to, again, do the surgery, because pre-formed chops are already there. And after doing irrigation aspiration, one can do an intraocular lens implantation, and everything becomes more clear once you implant an intraocular lens. Now, this case was in fact not planned for a corneal cataract surgery, but here DALC was being planned and a cataract was noticed. So cataract was also dealt in the same sitting. We've not reached up to the desmoids, but there's a little bit of stroma already onto the surface, and the cataract surgery is now being done. And after doing the cataract surgery, just as one would do routinely, foldable intraocular lenses put, and then the last layer just above the desmoids is removed, followed by the graft, which is then placed onto the surface. So this is again the post-op picture of the same patient. Now, this was in fact referred for penetrating keratoplasty, but this was a Fuchs dystrophy with cataract. So we removed the hypertrophic epithelium. Then the scarred desmoids membrane was removed and a desmotorhexis was done. Subsequently, the anterior capsulorhexis was done. So this was like a 3 rhexis in one. And then phacoemulsification was done, followed by foldable intraocular lens implantation. Here, you can be a little more liberal, because even if you are onto the cornea, it doesn't matter, but it shouldn't cause a rent in these cases, because that can be a disaster. And this was followed by a DSEC surgery, which was done, and air bubble was instilled. And over a period of time, it does clear up. And this is the pre and the post-op picture of the same at 5 years follow-up with good results. And I come to the last part, which is a DMEC triple. And here again, the Descemet's membrane is being removed to form a DMEC graft. Cataract surgery, which is being done, which we would do routinely. And then the descemetorhexis is done just as is advocated for routine DMEC procedures, followed by the graft, which is taken into the injector, is placed inside, and then you get the configuration of biceps curl upwards here. And once you get the biceps, now this is upside down graft because it's not biceps curl upwards. This is the correct configuration, and you inject the air bubble. So this is the post-op picture, 6x6, and this is at 1 month, where very faintly you can see the graft on a slit lamp. So to conclude, for high-risk cases, phacoemulsification should be done first. For good prognosis for grafts, combined procedures can be done, and you need everything. Your incision placement should be correct. The operating microscope should be good. You should have retroillumination on, nylon hooks, optical iridectomy, trypan blue dye, BSS plus, dispersive OVD may be required. Eccentric creta, eccentric rhexis may be required in some cases, and keep all your fluidic parameters low. Of course, counsel the patient that ambulatory visual acuity is what we may aim for in some of the cases, and not exactly at a visual acuity of 20/20 or 20/10. Thank you very much for